do some recruitment soon, so at least to get even for even 50, and then.
Welcome back.
Services. And just
Lovely
explain
lunch
your
there.
scenario and find out what this is.
Used to that kind of lunch in the NHS anymore, but I was thanks to Health Scotland. Okay, so let's make a start again. As I said, this afternoon you will hear from the sharp end, to literally to see exactly how it is for them, how the planning to implement VTP are going in various health boards. But before I do, just a reminder. Please don't forget, you can still use Slido to put your question directly to us. And as I say, at the end of the session, we will answer some of those pertinent ones. And also, there are lots of material available outside the room, health education material and immunization from Health Scotland. So save them, take them all back, pick them up, and take them away with you, relevant one, of course. So without further ado, this afternoon, as I say, there's a number of colleagues presenting from various island and health boards to basically give an update on where they are and some of the issues they are facing locally and some of the challenges as well, and hopefully also some of the opportunities they see to improve their existing service. So to start with, Christina Morrison from nurse specialist from West Nile.
So, I know. Hello, my name is Christina Morrison. I'm a health protection and screening nurse specialist and nominated VTP business change manager for NHS Western Isles. And as you can see by this emoji, my mind is blown. Is that better? Oh, this is terrible for me. So the Western Isles is a group of islands that spans 150 miles north to south of the northwest coast of Scotland. We have a population of 26,500, 9 GP practices, which are the red stars, and 14 clinical areas that service 12 inhabited islands. So we've got 5 satellite clinics, that's the green stars on the slides there. So year 1 of the vaccination transformation, we decided to concentrate on 4 programmes, moving them into 2 staffing service groups. Firstly, we put the school changes for the school flu programme across the Western Isles, and this has been completed. And we also moved the teenage booster programme, which is dip, tep, polio, MenA, CWY, and MMR catch-up in the Lewis and Harris area only, as a pilot in March this year. So that's commenced and is currently ongoing. We moved the services for the school team and the changes into the school nursing team remit. Whilst the school nurses already provided the nasal vaccines to children in primary school, at-risk children and mop-up clinics were carried out by GP practices. So we moved all of that into the school nursing team remit. Now, we've got staffing issues throughout the Western Isles for different areas in different ways. And in Lewis and Harris, we had a stable staff group. In US Dunbarra, we had to provide vaccinations to schools via the health visitor. So for a couple of reasons, we decided to do an at-risk clinic for the start of the season on the 1st of October, the first week of October last year. And that was mainly due to a delay in the nasal vaccine coming. Nurses being a wee bit scared about immunising primary school age children within the primary school and not getting it quite right. And for parental anxieties. So basically we were getting a lot of information from parents who were saying they weren't very happy that they weren't going to get this vaccine from their GP practice by the GP that they wanted. So we ran the at-risk clinic and it worked really well. We had 100% attendance and satisfaction was high from that, from the parents who were a wee bit disgruntled. So this year coming, we're going to move that into the school remit, so it'll all be done within the schools. Health visitors down in US, we only had one child who was at risk, so small numbers, and they just vaccinated them there, and that was that done. So we also had issues with bank staffing, so we had to put contingencies into place because we had sickness in the Lewis and Harris team, and we employed bank staff. But one consideration of that is the bank staff who were required to be vaccinating have to complete the PIP course, that's a Promoting Effective Immunisation Practice course, as well as having training on PGDs, because you can't work under a PGD if you're not trained in it. So we had to make sure that our bank staff were trained in both these courses, which again limited our bank staffing. So how did we do? Well, we got off to a flying start. This is the Barra plane landing on the beach, so I'm taking you for a tour through the islands while I'm doing this. And our uptick increased by 6.9%. It's put us above the national Scottish average on the interim data released yesterday for the first time for our school flu programme. So it's worked really well. However, our teenage booster programme, it's going. We started it last week and already we've got staffing issues. And we're piloting it in Lewis and Harris because of the main staffing issues down in US Dunbarra, but we again had staff sickness, so we only had one core member of staff doing this. We also have data sharing issues. Because historically the GPs have provided the teenage boosters in the Western Isles, it's been included in the global sum, so no data has been shared with the child health system. So we don't know who's been vaccinated and who's not been vaccinated. So we requested information from the GP practices to make sure that we were vaccinating the right kids at the right time in the right place. So we were given confirmation from the practices within the pilot areas that all children were eligible for vaccination. When the nurses went out on the day, we had to stop the session because 5 out of 10 children were double vaccinated. Somebody had assumed that they had been eligible. They didn't check the data correctly. Also moving on from that, we've done maternity pilots. Maternity pilots. So we piloted pertussis for pregnant women and flu vaccination for pregnant women in the US Dunbarra this time because we had staffing issues up in Lewis and Harris. So this went ahead. We got all the training to the midwives, and historically, getting data out of Southern Isles is challenging at the best of times for anything to do with pregnancy, never mind vaccines. So we implemented a spreadsheet that would record all the data. So they had to, as soon as they gave the vaccine, update this spreadsheet with all the details of the patient. And I'm just going to go over some of the issues that we've got with the data recording nationally as well as locally. So in Q4 2018, national uptake data for the practice areas only, so that's the pilot areas, sorry, the 4 practices that are in the pilot areas, showed that number delivering was 57.1%. For pertussis uptake data, you have to have 2 dates for the extract to carry out the information correctly. So if you don't have the date of delivery recorded in EMIS, the extract won't count the vaccination as delivered. In recognition of that, down in Public Health England, they're running a trial looking into a different age group and how to record this data and get it from the information systems that they currently have based on all women aged 15 to 55 who are vaccinated for pertussis. They've done this because women should not be vaccinated for pertussis unless they're pregnant. So looking at that, for the same data, same 4 practices, Q4 2018, 0% uptake. So that means there's a data recording issue there. It's either notification from the midwives to the practices and then not being put into the system, or it's just not being put into the system. However, the spreadsheet that I was talking about provided some data to us. So local recorded maternity data, we know we've got 22 women who were pregnant. I know it's small numbers, but it's a good way of testing things. 3 were not eligible, so they weren't over 16 weeks. 19 were offered, so that's 100% offer, and 17 were vaccinated, so that's an 89% uptake, going by local data. For the flu, same issue again, notification maybe it's just inputting into EMAs, but the flu portal data from all the 4 practice areas recognise a 2.8% uptake. Our spreadsheet provided us with information to say that we've got an 81.8% uptake, which, going by last year's data, is a 45.8% increase on a 36% uptake last year. So it looks like we're doing okay. We just need to get the data sorted. So learning and reflections from year 1. We need streamlined data systems. We need standardisation of systems for recording. We need effective and clear communications between practices and the board. And we need additional staffing, specifically in the school team. So moving on, in year 2, we're looking to schedule on the 1st of April, which is fast approaching, the rollout of pertussis delivery vaccine in maternity and flu, I should add, I missed that one out. 0 to 5 routine childhood immunisation programme implementation. On the 1st of October, we're looking to implement the 2 to 5 flu programme and all other adult immunisations, including flu, shingles and pneumococcal, and those at risk on the 1st of October 2019. But I have to say, we're already having a delay on the 0 to 5 routine childhood immunisation programme, and that's been rescheduled until the 1st of July this year. So we're going to do this slightly differently to most areas. Immunisation team is not viable in the Western Isles, 1, because of geography, and 2, because of our service needs. So when I did some modelling on a system called Guru, which is really good for proactive modelling on your vaccinations, you put in 5 years of data and then you get all your modelling for that coming year. It showed us that we had a variation of 200 to 500 per month in different areas of vaccines, and a peak of up to an additional 5,000 in October for across the Western Isles. So we're going to put delivery into the treatment room using the integrated treatment room model, and we're going to combine the treatment room changes, so that's your phlebotomy, your ECGs, your dressings, all the rest of it, along with vaccinations, but prioritising vaccination going forward into the GP practices, so we've got an equitable service for our population. This team that are going to be delivering it is a community nursing team, and they've been provided with training for vaccines, the PIP course, as well as paediatric life support, because they were quite nervous about going to babies and to older children as well, so babies and older children. And we have standardised templates for them, so that all the read codes and everything will be implemented into a template rather, on the EMIS system, and it'll be replicated right throughout the Western Isles. So that way we shouldn't have any errors in recording the data. We're going to implement a phased approach to call and recall, and that's because we've got more staffing issues, but this time in primary care. So to be able to run call and recall from SIRS for the 0 to 5 programme, we have to have it stabilised Currently, we've got an 8-week backlog, and we've had retirement where a lot of information has gone with a person that's retired. We're also trialling remote monitoring of fridges, and that's because we can't possibly be in all the 14 areas all the time. And it's a very stable way of making sure that the cold chain and safety of vaccines is in place. It will also help us to, just with our ordering, and if we ever have any weather issues, which we commonly have. So the barriers that I've highlighted today is our geography, the remote and rural. It's very difficult to implement an immunisation team across the Western Isles unless you do it in a robust and resilient established team. And our way of doing that is the community nursing team. The weather, it's challenging at the best of time. Movianto over the last 2 years has had to fly in vaccine for the flu programme twice. So that's 2 years in a row they've had to fly in just because of weather issues. Hidden knowledge, like I said, people retire, they take all that knowledge with them, and there's no resilience, there's no processes written down. So we're going forward writing everything down and making sure we've got flows for everything, just in case that happens again. Data access, that's really important for us and for the safety of vaccination programme in the Western Isles, and the sooner that we can get the joint data agreement signed off, better. Pace of change has been an issue. Whilst we've been training and concentrating a lot on the community nursing team, there's been a wee bit of apathy in the progress of the training, because we've been telling them since last year that this is coming, but middle management seem to be saying to their team, oh no, it's okay, we'll do that next week, and so it goes on. And 2Pay is another thing that's unique to our island. It's stimulated fear for jobs because people don't know exactly what's happening within the practices. The practice GPs are saying to the practice staff, it's okay, we'll employ you, there's no changes happening here. And then we're coming in asking for 2Pay, they're hearing about it, and arms and legs, and people just talking. And some people are saying, what about my job? I did an immunisation training day, and the practice nurse recognised that out of 20 of her appointments that day, 18 were treatment room, and they would be changed over in the process. So she had a fear for her job. So we did a little bit of, it's okay, don't worry, we'll look after you. And as well as 2Pay, it takes a long time. You have to do job matching, you have to go through a system and a long process. We've been going through it for the first year, for a year. We still haven't finished that off. So we haven't been able to advertise any of the jobs that we've identified for going forward. So opportunities for us is that we're going to have a robust and resilient workforce. We're going to have flexible vaccination service, initially definitely. I don't know about the future, but it's going to be based within the GP practices whilst we're changing it, and we're hoping to replicate that so the flexibility continues. Standardisation of care, because everybody will be trained up to the same level, at the same speed, at the same time, as well as standardisation of the templates, so all the data recording will be done correctly. And collaborative working, and hopefully pragmatic solutions to services. So in some areas where there's very small numbers, maybe an isolated island, and a GP is going to do a 2-month check, say, on a baby, maybe he'll vaccinate that day and we'll do something else for him in return. So we have to look at it that way. And that's it. My nerves are now calm.
Okay, I won't make you sit there just now, but at the end of all the session, everybody will come to the front. Elvira is next from Ashanaran, Consultant Public Health.
Hello, can you hear me? Yes, okay. If anyone at some point can't hear me, please wave your hand or something. So I don't have a presentation because I wanted to be a bit flexible in when I would be hearing comments from colleagues today. And one of the things that we heard this morning was about the perspective from GPs. And I think that it might be helpful to try to explain why it is a bit difficult to progress. So when we started to talk about the vaccination transformation program, it initially was going to be a project undertaken. Initially, the initial request came to the directors of public health in 2017, in fall, if I remember correctly. But last year in January, it changes. It changed suddenly, and suddenly it's part of a process with the primary care transformation that happens as a consequence of the general medical contract. So this is a change of the way that it's going to be delivered, and you need to adapt to that. And at that moment also changes another thing. Initially, it was going to be a nationally coordinated model when we were going to explore similar changes at the same time. For example, all the boards were going to explore children at the moment or maternity, but it then started to be a very much local decision-making process. So these were two changes that have affected quite a bit how we have been able to evolve later. So in that moment, in January 2018, we set up our local VTP implementation group with the local people that have been delivering vaccination and have been on the field on vaccination. And at the same time, the board and the partnerships agree on a structure of governance for the whole of primary care improvement plan. So it becomes quite complex because the VTP leads are supposed to be leading, but the decision is not necessarily happening in VTP. So you need to agree with other stakeholders that also have in mind other priorities happening in primary care, what's going to be implemented and where the money is coming from, what resources are necessary. I understand the situation and the GP practices, and I see that the benefit and the end to free resources that are needed for GPs are very important. And I also understand about the coordination, but it means that it's becoming challenging. So, and I think I can speak of a couple of challenges. So one of them is last year we were trying to decide the priorities. So there was a process with several layers of governance trying to agree. So the VTP group would make suggestions of this is the things that we can implement, and then we would have several rounds of conversations with the partnerships, with primary care, and with the GPs themselves, trying to agree what was achievable. At the same time, all the structures were set up, and at the same time, a big part of the focus was in the developing of the primary care improvement plan. In Ersar and Arran, we have 3 localities, and the decision was to have a pan-Ersar plan when the decisions would be taken pan-Ersar. And the focus would be in writing the plan, which by the way, I think it's a very good plan, and I think it's expressing very well how the focus should be. But getting there, the plan wasn't approved until July. So it explains why it was difficult to approve, because if the focus in the people that you are working with is in trying to agree the plan, it's difficult to focus in the details on how we're going to implement something. So around May, we agreed that the priorities for year 1 were going to be childhood. In Ersar and Arran, we have 2 partnerships where the immunization is delivered by board staff, and the other one, the majority of them, is not. So the request was, excluding flu, try to have to transfer north, but consider if having a pan-Ersar approach could be the best model. So basically we were thinking, okay, we're going to explore the possibility of having 3 localities or 1 locality. And we started to work on that in May, and the VTP had a view on that around June. But there were differences of opinions between the partnerships and between localities. So we have spent the whole of summer, the whole of fall, trying to develop further this model, trying to look at potential tweaks on this, looking at organizational change, trying to agree a solution. And at the end, we haven't been able to find consensus, which was the preferred method for primary care improvement plan. So in January, we realized, no, we're not going to get consensus. So we go to the individual 3 partnerships that, which are, by the way, is where the budget is. The VTP leads do not have control of the budget. The budget is in each one of the IJBs. So each IJB had the view on how it was going to implement in the area, which means that for North, it's a significant challenge, because South and East are already delivered by staff, but North isn't. So we are working now with them trying to find out how to implement that. So it's not that we haven't been trying, it's that the decision-making process is complicated. So the other of the challenges was travel health. So travel health, what we did is try to scope the provision of travel health in our area. So we have a document explaining that, and basically it's very fragmented. Depending on where you are, you could be having easy access to a GP practice when they would do anything for you or not, or you could have easy access to an specialist clinic or not. And we have been working with other boards and Scottish government, because there is a thought that maybe the model that is going to work is to have an initial triage system, maybe on the phone or online, when we could be classifying patients in depending on their needs. So there could be people of low risk. If you are traveling to, I don't know, Italy, maybe you are not going to have anything particularly different from Scotland, so you're not going to need anything relevant. But depending on where you're traveling, your risk of infectious disease might be higher. You're going to need vaccination, you're going to need malaria treatment, and you're going to need to receive advice on what to eat and where to, what kind of foods you would be better not to eat, or what kind of precautions if you are height kicking or something. So if there is a national triage system, then there's a thought that part of the advice, depending on your level of risk, can be done through the phone. So we have had several workshops on travel health with colleagues from other boards, and it's progressing slower than we would like to. I think we are getting somewhere to develop this model, but still need to clarify what kind of advice could be available at a national level. And the advice that can be available at the national level would have implications for what would be the resources needed locally. So I would really, really like to transfer travel health. I think we are not there, and my personal opinion is that it's better if we get it right. So for vaccination, I think it's very important that we get it right, and because the consequences, if there are outbreaks and there are infectious diseases, would only not be for public health. It will be for public health. If there's an outbreak, it's me. It's me, my team would be the ones dealing with that, but it would also be GP practices with the patients in their doors, and would also be the hospitals. And flu is a clear example of that. Depending on vaccination levels, we could be less or more worried if there is a higher transmission of flu or higher severity. So this is one of my worries, that we need to get it right. And I think that it's not clear of how complex immunization can be. And I'm just going to use as an example the third thing that we wanted to implement in year one, and has been the one that we have transferred, which is pregnancy immunization. But even pregnancy immunization, which is one of the easiest one, is an easy, less complicated than others, has been extremely complicated. So why it's easy? Because it's easy to identify the patients. So there's pregnant women are recorded as soon as they are pregnant and they go to their provisioners. So it's easy to identify them. So pertussis and flu, there's no contraindications that would worry them as much as it would happen with shingles. So they are easy to identify. The contraindications are very easy to identify. There are also adult people. So there's a potential for duplication. So right now, a woman in Ersan and Aran could get the vaccination for flu in their maternity services. But if they are at risk, they could also get this from the practice. And if they work from the NHS, they can also get it from the NHS. So there are 3 potential places where a pregnant woman can get this. But if it's an adult woman, they are going to remember if they have been vaccinated, right? Well, not always. But imagine if this is for a child. If this is for a child, we need to get it right. And they are not vaccines that would worry us too much if they don't get duplications. But we have received complaints from parents when they have had vaccines in duplication, even if we are not worried, but they are. So we need to get it right. Okay, so vaccination is an easy one, and especially because the alternative model is clear. So for vaccination, immediately the decision was maybe the way to get this is with maternity services. And maternity services embraced the change. My understanding is that might not happen in other boards, but in our board they say, yeah, we're going to do this. So we're going back and we're going to think of how we think this can be done. And you think, well, it's easier because 97% of the women are managed by maternity services and 97% get a scan. And there's a maternity unit, so we get it. Well, it's easier for pertussis because pertussis can be given from the week 16 and the scan is happening at 20. But for flu is only given for some months of the year. So you need to have a backup plan for the women that cannot be vaccinated during that 20-week scan. And the thing is that there's only one maternity unit in Ayrshire, which is in Kilmarnock. So for the women that are used to get that vaccine in rural areas, we are asking them to be vaccinated. And so we had a model, initially it was 2.5 registered midwives. And I highlight registered because to operate under a PGD, you need to be a registered practitioner. So you have to use registered practitioners, which means band 5 or higher, which means that some of the nurses that are used in other areas for the primary care improvement plan, like phlebotomy, are not the same ones that are going to be doing vaccination because the banding is different. So we decided, okay, 2.5 midwives. This decision was taken in July. Flu season starts in October. And we say, no, it's no problem. The scrutiny panel, there's been a pre-approval of the money. So if we get this right, we're going to be able to advertise very soon. Advertise went out in August. I think that the recruitment of staff ended in January. The flu season started in October, and it was transferred in October. How did they do it? Because the maternity staff was very nice, and they agreed to have extra hours with the existing staff. If they hadn't done this, we couldn't have done this. So because they did, which means also training of multiple staff. It means that the staff, public health has had to train not only the staff that has been hired in January, but also the staff, the existing staff that were going to do extra hours. I think we have done 5 sessions in total, including community midwives. So there's challenges. For example, rural, we have discovered that there are many. There are women that receive maternity services in our board, but go to the GP practice in another board, or the other way around. So if the message that we have done a lot of communication, social media, press release, emails to GPs, maternity, neighboring boards, but there are women that then went to their GP and said, no, you have to go to your midwife for vaccination. And the midwife says, no, you have to go to your GP. So there's 2 possibilities, that women will be fed up and not get vaccinated, or they will complain. If they complain, then you get inquiries, and some of them from elected members, some of them very urgent, some of them very high level. And we got several in November. We did another round of trying to communicate all of this. So, and basically the model that we agreed is that for this first year, the majority of the women would be offered vaccination in the maternity unit, either in the 20-week scan or another appointment. And the women would have to phone to a number themselves, and then they would be offered an appointment. And if they had difficulties, then a solution could be found in case-by-case basis. But we know that there have been some difficulties in people in rural areas when in a few occasions they have been told, no, you have to go to Kilmarnock. That's the only way you can do this, even if this was wrong. So, well, one of the things you want to do with a new program is to monitor this. So, yes, but the problem is how you get the data. The data is, there's a system in the maternity unit called Eclipse, and there's a different system in GP practices called MS. And for those that you know, MS has had some problems in the last few months in some areas of Scotland, including ours. So we didn't get any information from MS until January. But we asked our people in maternity services. What they did is they recorded IMAs. They record the vaccination in a spreadsheet and then send that same day a letter to the GP practices, which were asked, please record this in the IMAS system as soon as you could. So what we found in January is that for pertussis, it has always looked very well. So the number of vaccines has been significantly higher than in previous years, but for flu, initial record showed that for IMAS that it was for pregnant women not at risk, very similar to last year, which was something like 53%. We were a bit disappointed because we wanted it to be higher, but it is what it is. But for women not at risk, initially it showed 32.8%. For women, the women not at risk are the ones that were lower. And previous years it was 52. So we thought that there could be some under-recording because the maternity services have told us that they have been vaccinating more than 1,000 women, and the number of vaccinations recorded in IMAS were something like 750, so 25% of them have been under-recorded. So we have been trying to sort out the recording problem. We have had more communications with GP practices, but we still think that the uptake rates are not as good as we would like to. And with this, I don't mean that they are worse than previous years. I think that there was an expectation that it was going to be a real improvement. Not that much yet. Although for next year, the plan is possibly to use more community midwives, and the Best Start program is happening in North, just to try to target them more locally. So we think that next year we can do it better, but which means that the transfer of immunization services hasn't finished. It means that still there's some workload to be done there, some more training, some more monitoring. And this is maternity, which is the easy one. Sorry. So some of these difficulties in another types of program could be significantly more difficult. So what's our plans for next year? We still have to agree with other partners following all of this, but we need to agree a way for childhood immunization. We want to progress in travel. I would be delighted if we clarify which could be the national system, and then we manage to set up a local system. We want to also have some mop-up for school children that leave early. Thank you. But this also is in the context. Remember that the majority of immunization coordinators here, the BCMs, the VTP leads, are also immunization coordinators, which means that we are still responsible for the normal immunization bit. Last year, that meant that there were several flu vaccines introduced. There were shortages or delays in the availability of these vaccines. This was an incredible amount of work time that we tried to cope with. The normal, most of us also work in health protection, so that also has their own challenges. And for next year, possibly we will have to implement HPV for boys, and there will be new vaccines, flu vaccines coming to the program, which means that the same people is going to try to coordinate this, is going to the same one that is going to try to look at these other programs. That's a pressure. That's a difficulty. And also, if there are boards next year that want to implement something in flu, they will have to look at which are the vaccines. How are we going? Oh, by the way, also it means fridges, which fridges, and how we're going to order the vaccines, how we're going to get the cold chain, who is going to look at this. Premises, staff, so every decision is a chain. So it's much more complex than it looks like. I will finish saying that for me, the main challenges for next year is, apart from, in general, the decision-making process and resources, and I not only mean resources for which nurses or which staff is going to do this. It means not only the immunization coordinators and our team. I think that some of our colleagues in primary care are stretched trying to work through the different strands from the primary care improvement plan in addition to their jobs. That includes GP representatives, that includes primary care. It's complicated and challenging to try to do all of this without the resources to do this. But things like for me, is the decision-making process. I think that in ERSA and ARAN, we're trying to make it better, to make it clearer how it works, and try to improve the way we take decisions. But it is challenging. But things like I would welcome a clarification of premises. I would welcome a clarification of what's going to happen with the funding post-VTP. The GPs would welcome a clarification of how the payment of the money that they receive for vaccination is going to work. I think we have got something recently on this, but it's still worries there. So this is where we are. We're hoping to transfer more things, and one of the things that really need is IT systems. The data recording is a problem. At the moment, the only thing we can do is duplicate it, but it's one of the things that we need to get it right. And it will be very difficult to finish implementation of the immunization programs without the definitive IT system that's going to work. So I think that's it. Thank you.
Thank you. I take it, obviously, given the challenges you face, have you any thought about the 2 to 5-year-old flu and the adult program, or have you not?
Not yet.
Not yet. Fair enough.
No, although
I just want to give you an opportunity, but that's not.
It's still under discussion because we still haven't agreed which are the priorities to implement in year 2. So we could have that our colleagues from the GP sub insist that it is to be implemented. So yeah, might happen.
Okay, super. Thank you. No doubt the police will come up in that discussion as well. So again, as I say, I'll get everybody on the front table once we finish everybody. Next is Ryan Prentice from Dumfries and Galloway.
Hello, I'm Ryan Prentice. I'm the Vaccination Transformation Programme Project Manager for NHS Dumfries and Galloway. So I'll give you a bit of an overview of where we're at and our plans for the future. I'm just going to skip that slide and come back to it. So where we're at just now is that we already provide 60% of the preschool and childhood immunisations across Dumfries and Galloway anyway. We have a team of nurses that go out to the GP practices and they actually deliver this on site there. So we're actually just extending that model out across the whole of Dumfries and Galloway to all the GP practices that we don't currently serve. Some of the learning from that is that the nurses ordering their own vaccines, that works well. The other thing that we already do is all the schools. So we already provided all the school vaccinations right across Dumfries and Galloway anyway. And some of the things that we find from that is that the forms are not returned. And this year in particular, we had an awful lot of times that the egg allergy question just wasn't answered. And we had to phone so many parents. I mean, we heard this over and over and over. If they go and they give a presentation to the school and literature 2 weeks in advance, they get better responses, the forms are returned better, they get less needle phobia, and that actually works well, so I would do that too. If they come across issues with the school, with the premises or whatever, flag them up, don't put up with them, raise that, do something about it so that it's sorted for the next time. And have a named nurse for the school. That provides a point of contact, and that also works well. We've also found that there's some pockets of resistance, and we're not really sure what that is. We think it's possibly parents talking or something, and we've never really bottomed that out, but there seems to be some areas where we just see a lower uptake. The other thing that we're going to be doing is the bloodborne viruses, and we already work quite closely with the third sector in the west of the region, but that's not something that we have right across the piece, and that's something we would look to build on. We also have to have a think about the data protection issues when you're providing the booster for ex-offenders, prisoners that are released. Obviously, if there's a letter coming out saying they've just been released from prison, well, it's a bit of a giveaway. we've done a little bit of public engagement, and the points that came about are similar to the points that Rachel mentioned earlier. You know, having the information jargon free, trying to look at automatic reminders or ringing people, but that's maybe a wee bit aspirational. That's incredibly time consuming if we were going to do that. We were just talking about it. If we did Dumfries for flu, we're talking 18,000 people. So, you know, that's maybe something to think about in the future. They had said for older people that go to daycare centres, if you could provide good information to the daycare centre manager, then that's information that can be passed on, and that would encourage uptake. They also wanted to use local services, so we're probably not going to be going into community halls and churches, but we can try and make best use of some of the cottage hospitals and community hospitals that are around about us. And we're thinking about vaccination centres in the urban areas, so we are looking to see if we can actually start and provide some of the campaigns from centres, so that we can do large numbers and we can spread them out over a period of time, because one of the problems that we would have is accommodation. If we were going to do a flu campaign over, say, 8 or 12 weeks, we can't just get the rooms for that length of time. One of the other issues that we have for everything that we ever tried to do in Dumfries and Galloway is transport. And so people are saying if there's information can go to carer services and whatnot to try and help, and befriending services to actually get people to vaccinations. So year 2, this coming year, we're going to be extending all the preschool. We're going to start in April. We should actually have more or less all the practices covered. The bloodborne viruses, we would try to pick up those boosters for people that have disengaged with drug and alcohol service or have been released from prison from June this year onwards. And then what we're going to do is we're going to identify 9 practices, and we're actually going to take over all the vaccinations for those 9 practices. So we're not maybe going to do it by vaccination type, but we're actually going to identify practices and try and take on everything for them. We're then going to have a look at the flu this year for those practices, and also for all the preschool, all the childhood flu. The pregnant women, we're looking to try and pick that up at the 20-week scan. So we've got a proposal going to the Primary Care Transformation Programme Board to recruit a nurse to actually do that in the scan, because our scans are spread out over the course of the week. And then we would hope to pick up the adult vaccinations, maybe the herpes zoster and the pneumococcal, from January and February next year for those 9 practices that we've identified. We're hoping that we'll reduce some of the health inequalities by moving to fortnightly rather than weekly clinics for the preschool. So there will be more clinics offered. We're going to 15-minute appointments. We were using 20 minutes, but we found that we can do it quite safely in 15 minutes. And we should be able to provide a more uniform service right across the whole of Dumfries and Galloway. We do, however, have issues, and they're the issues that you're going to hear from everyone else. We have recruitment issues, IT's a problem. You know, we have to think about the opportunistic vaccinations if we're moving to fixed clinics. We need to think about accommodation, and we're going to be taking this phased approach. The workforce, though, is quite an issue. We have to recruit nurses. That's not easy. We've had a lot of problems trying to recruit midwives, so that's why we're going down maybe a nursing route for that. We're not exactly sure of what the admin ratio required for this is, so there's a bit of testing with that. There's obviously the challenges of seasonal working, and we're having a look at annualised contracts to maybe be able to handle that. There's changes to the actual nurses' contracts themselves. We have some paediatric nurses or childhood nurses that are doing the the preschool and childhood vaccinations, and some of them are not too happy about maybe moving on to be doing adults. And we have to still think about the whole travel health. We're really looking to see what the national model is for that. So just going back to the uptake rates. So because our preschool model is really not changing, we're just extending it. We expect that to hopefully be unchanged. The school model won't change at all because we already do it. We could possibly see an increase in the bloodborne viruses if we're able to target that. The influenza, we would hope we can match that by having longer campaigns. We're probably not going to have the drop-in sessions. We're probably going to appoint this, but over a much longer period of time. The pregnancy, well, most of the pregnant women will attend their 20-week scan. It's quite an exciting point, so we're hoping to be able to get a good number there. And the adult vaccines, well, hopefully we can maybe have a targeted campaign for that to increase the uptake there. And again, the travel health, well, we don't know because we don't really have very good figures on it. I'm not sure that anyone particularly does have good figures on it. I think it's sometimes down to the way things are coded, but we're not going to know. So, yeah, that's where we're at.
Thank you. Okay, Scott Honey from Greater Glasgow and Clyde.
Okay. Okay. Hi folks, my name's Scott Hanley. I'm the interim, I'd just like to point out, vaccination programme manager, and I'm covering for my colleague Jen Reid, who I believe is watching us online. Hello Jen. So I've got my first class ticket to Brazil booked for Monday when Jen comes back, and I'll leave this all to her and she can take over. So good luck Jen. No, I'm only kidding. So I just thought I found this nice picture here, which I think sums us all up quite nicely. This is all the health boards in Scotland, and it was just really to focus in on Glasgow and Clyde and what we're all about. Thanks, Dan. Yeah, side. So from this picture you can see, I mean, our colleagues have already touched on some of the challenges they have, certainly in the Western Isles and Highlands. You can see some of the major challenges can be geographical challenges. But Glasgow and Clyde is just this tiny, tiny, tiny health board in the centre there, and I don't know what we're complaining about. Everything should be very easy in Glasgow and Clyde. So this is our health board. The main challenge we have is not the geography that our colleagues in Highlands and the Western Isles have, and other areas such as Orkney as well, so it's an archipelago. We have our main challenge is our population. So the population of Glasgow and Clyde is 1.2 million. Scotland's 5.4, so we're sitting at 22.2% of the population, sitting in that wee tiny area that you saw in the previous map there. We have 6 HSCPs, so they're on the map there. Inverclyde, Western Bartonshire, Renfrewshire, East Renfrewshire, Eastern Bartonshire, and Glasgow City is 1, and it's divided into 3 locality sectors, north, east, northwest and south. And not to take away from that 1 HSCP, because Glasgow City represents half again of the population of NHS Glasgow and Clyde. So that's a big HSCP. So that's our main challenge. We also have 38,771 staff. I just thought I'd mention that for those who are interested in the staff flu uptake in NHS Glasgow and Clyde. It's quite a challenge to achieve the 60% uptake target that's been set for just that flu season there, because we've got 38,771 staff to try and convince medics and nurses that the vaccine doesn't give you the flu and it doesn't make you ill, and it works. So that's Glasgow and Clyde. So just to set the scene there. So for year 1 then, we decided to go ahead with the routine childhood programme migration in Glasgow and Clyde. There was a number of reasons behind that. First of all, it had to move at some point. Second of all, and this is a personal point, arguably it's the most important programme, and that's maybe controversial, but protecting babies and infants, of course, against some of the most serious respiratory airborne diseases that we know, meningococcal, pneumococcal, etc., perhaps arguably is the most important programme. So that was 2 reasons. The other 2 reasons There were other pressures, as you know, in terms of childhood health, and that was to do with the universal care pathway. So we knew it was impacting on our staffing levels, and we knew that we had to make a move sooner rather than later. The other aspect as well is that the call, recall, and schedule and recording, which have been touched upon in some of the presentations already, actually was relatively easy for this programme because there's an infrastructure already in place. The SIRS system can call, recall, and I must mention, since my colleague here, Fiona, who used to work in screening services in Glasgow and Clyde, I just mentioned the IT data. The IT and data needs to be operated by somebody, and in Glasgow and Clyde, that's screening services, so our child health support team. So there's a whole infrastructure around about there in terms of recording, data sharing, call scheduling, and call recall. So that was in place. So although it was quite a big cohort for Glasgow, did I mention that there? I don't think I do. It's 51,000 in total, 12,500 to 13,000 births per year in Glasgow and Clyde. So although it's quite a big cohort, the structure that was there already. So that was some of the decisions of why we decided in year one to go ahead with the routine childhood programme. So we migrated from 235 practices in Glasgow and Clyde to 40 community clinics. These are mainly health centres, mainly. There are two or one exception in East Dunbartonshire where it's an acute site. It's an ACH site in Stop Hill. And we may have another, we'll be moving into another acute site as well, which is the New Victoria Hospital. So 40 community clinics, and these are hosted and run by our Children and Family Services, HACP teams. So in Glasgow and Clyde, 60% of our GP practices, so 143 of the 235, are located in private premises in the community, and 40%, which is 96, are located in these health centre premises that I've just mentioned. So our biggest concern, of course, was where you centralise any service, you can compromise service accessibility, and therefore you can introduce inequity to the service. So that was our main concern. So to try and mitigate that inequity, we analysed health centre accessibility to the patients attending those practices out in the community. So there was various ways to do that, just local knowledge or using Google Maps to visualise where the centre lay and where the GP practices were located within the locality. And we also obviously looked at the immunisation cohorts, and that's easy to do. You get the lists from the GP practices, and our screening services colleagues provided them. We can map that per health centre to know what flow of patients you've got coming into each health centre. And so, as I mentioned, the cohorts we're dealing with, it's 12,300 to be exact, 12,500 to 13,000 children per annum, depending on the birth year. And also, as well as that, we conducted an inequalities impact assessment on this service to make sure that we were addressing all the equalities and the inequity aspects of the service. So I mentioned our children's services teams have taken over the programme from the practices. They've moved it into these new health centre locations out of the practice premises. So we're imagining that already there's an impact in the practices in terms of these families are no longer going to the practices and waiting in the waiting rooms in the GP practices. I think there was mention of the GPs not noticing, perhaps not getting the direct impact of certain programmes moving in terms of their workload, for example. But they must be noticing that the practices are emptier because there's no more clinics being organised in the practices. Also, the practice nurses are no longer involved in vaccinating. So that must be freeing up those practice nurses for other activities. So our children's services, so what we've done, we have formed 4 cross-HSCP childhood immunisation teams, and I'll touch upon that in the later slide. So that's the teams there. So Inverclyde and Renfrewshire, I call it Team 1, 2, 3, and 4, but that's not obviously their real names. So that's the cross-boundary HSCP teams that we're managing in Glasgow and Clyde. And this is how it's structured, and we took inspiration from our school immunisation team approach, which we implemented a few years ago. So I won't mention school immunisation really in terms of the VTP because it's already been reviewed and re-engineered in Glasgow and Clyde. And it's this same structure and approach that we deliver our school immunisations across the board area. So we have a childhood immunisation team lead, which we have just recruited, and 4 band 6s, they'll be the leads for each of the 4 teams, with that business support obviously, and we've calculated based on a 15-minute immunisation appointment session we need 45.5 whole-time equivalent immunisation nurses. These are band 5s. Now, there's been a gap analysis done across the teams to see what the recruitment requirement is. There's been a delay in implementing this model, basically due to year one landscape navigation, let's call it, in terms of funding releasing and decision making in terms of what the priority. I think Syed touched upon this. What are the priorities in the primary care improvement planning? So although we had a bid put in for this in March, April last year, we were a wee bit early in the day actually in terms of the decision making process. And as a result, we didn't really receive the funding to implement this model until mid-November last year. So that's halfway through the year. So as a result of that, the recruitment for this team has only really commenced in earnest in the last couple of months. So that's the impact of people finding their way in this new process, in this new landscape. But I'm happy to report our immunisation uptake. So in red there are 3 of the HSCPs who were early adopters of this model. And we can see this is the uptake for up to 12 months old. This is from ISD Scotland, of course. And from our early adopters, especially in Strathclyde, we've noted that the uptake is maintained high. And in fact, has actually increased slightly. And we haven't drilled down into the reasons for that yet, but we suspect it's because we're running more frequent clinics. And also the chase up, the recall, is more stringent. The clinics are bigger as well, and so we feel that the capacity has been increased because it's a team, it's a larger venue that's been pulled in. So we've got a bigger team, more frequent recall and more stringent recall. That's our suspicion, but we'll need to look into that to provide evidence. And the uptake again, by 6 years old again, just highlighting, hasn't been impacted by the migration. And I'm just highlighting the 3 HSCPs again, the early adopters. So that's good news, But of course, as Syed highlighted, if you drill down, there will be pockets where there's lower and higher uptake. And of course, that's always been the case. We'll need to analyse that and introduce interventions if required. So that was year one. And we've almost finished it. Of the 40 health centres, we have one which should be underway very soon in Eastern Bartonshire. I think I mentioned Stop Hill, and one that we are still trying to find accommodation for. So the 2 main challenges have been, because of the cohort sizes, accommodation, suitable accommodation, and that's for waiting areas for families with buggies and prams and all that kind of thing. And the other issue has been the inheritance of queue lists. The inheritance of usually the preschool booster is the one that's been delayed, and therefore having to clear those queue lists before the clinics are up and running. So that's been 2 of the main challenges in that programme, as well as the timeline, of course. So for year 2, we say year 2, we call them plans, aspirations, in brackets, please God let it be. For year 2, we are hoping to pilot the preschool vaccination, flu vaccination. I missed it. No, I've got flu. Preschool flu vaccination. We're going to be using the same venues as the routine childhood clinics, and the reason for that is that our children's services teams are going to take on the ownership and leading of that programme. However, because it's a transient programme from between October and November, mainly early December, mainly the immunisation team will be made up of bank staff, so we've got a dependency in the bank. And we'll need to have discussions with the bank because that dependency is going to become a common theme across the programme. So we're going to have a discussion with our bank colleagues in terms of capacity, especially at that time of year. So immunisation, mainly bank staff, and it's mainly over a 10-week period. Some of our GP colleagues have commented recently, but the flu programme goes to March. But we know very well in terms of the uptake, as soon as you hit January, February, the figures increase very, very insignificantly. A matter of few patients perhaps in a week. So the main uptake is achieved between October and early December. So that's why we always plan in a kind of 10-week window. We're planning on a 7.5 minute per vaccination per child. That's our modelling, and that's how we're going to calculate how many nurses we'll need for each of the sessions. And the reason behind that is it's just the one vaccine, unlike the childhood programme, and it's an intranasal spray. And that's the model we used in terms of the school programme as well, and it's worked very well in terms of planning and bank nurse calculations. The clinics will take place late afternoon, early evening during the weekdays, and potentially Saturdays as well. And again, that's to try and remove this kind of clash between, because we're already using those venues for the routine programme. So the routine programme will run 9 o'clock, possibly to 3:30, and then the flu clinics will run a little bit after that to a later opening. So we've had to investigate later opening times for the health centres, and by and large they're open to 6:30, so that's achievable. The cohort size for Glasgow, 31,500 preschool floors, and that's 2,363 a week. That's at a 75% uptake over 10 weeks. So not a huge, but a significant cohort to achieve in a week across the board area. So as I say, Test for Change planned from the Monday, the 30th of September, and we're at the moment we're agreeing the victims, the participating centres to be agreed. So already we've got New Gorbals Health Centre, Castle Milton, the detailed planning of that, the actual using the modelling that we use to calculate how many nurses. We're going into the nitty-gritty of how to get that delivered. However, we have, which has also been mentioned, a kind of common theme here, we've got a dependency. We'll have to develop local contingency, IT and data or processes around about the call recall in the next 6 months. So we've really got April to September, this next 6-month run up to September the 30th, to work out what we're going to do in the meantime to schedule. We can identify via the CAI, but we'll need a process in terms of getting those children listed, scheduled, and then once they're vaccinated, recorded as well. And again, we'll need to share the data with the GPs, and national uptake reporting will need to be conducted as well. So at the moment, as Syed says, that's all hinging on the GP practice systems just now. So when we're talking about moving that out, how do we report national uptake? So we'll need to look into that. So we've got 6 months to come up. We think we can achieve it. We've got some ideas around about EMIS community, and as I say, using the CAI to identify the children. So we feel we can pull something together in that time. This is one of the slightly easier ones. But we do have a dependency. There are a small group of children, 6 months to under 2 years, who are still in that preschool group. Now for Glasgow, it's about 200 children, but the vaccine must be offered to them. And that's those children, those infants who are at risk and in a risk category. So we must get that data from the GPs, because that data is only held in the GP systems. So we'll have to negotiate and establish a secure process, getting that data out, patient identifiable data, in order that we can call these children for vaccination. So the uptake currently in Glasgow and Clyde for the preschool flu is 54%, but it's around about 75% for primary school, the primary school programme. And I'm going to point out my colleague Emma Findlay over there, who's the school immunisation lead. So 75%, so quite clearly, there's a significant difference in the uptake. And that's because you've got a captive audience of Waynes who can't escape getting sprayed up the nose. So clearly we've got an opportunity to improve or align that uptake in our new model, and hopefully we'll achieve that. Pregnant women is our other aspiration, brackets, please God make it happen, from this flu season. Monday, 30th September again, basically October, the next flu season coming up. So we've got 6 months. So we have negotiated very adeptly and carefully with our midwifery colleagues. My colleague Syed Ahmed here, the two of us as a dynamic duo, trying to negotiate with our midwifery colleagues and convince them that the best way to move forward with immunisation, like our other colleagues and other boards, and we've used that as inspiration to try and leverage the deal that Ayrshire and Arne have moved forward, and other colleagues have moved forward with this model. So we will be offering the flu vaccine from the 12-week booking appointment. We'll be offering the pertussis and flu, if they haven't had it, at the 20-week fetal anomaly scan, and any other antenatal opportunity prior to. So if there's an earlier meeting for some reason, for other reasons, with the pregnant patient, or afterwards, we'll be offering it there as well. So the venues mainly are going to be GGC's maternity units. There are three main ones: Princess Royal Maternity, which is part of Glasgow Royal Infirmary, the Queen Elizabeth University Hospital, and the Royal Alexandra Hospital. The last one in Paisley, and the Queen Elizabeth University Hospital, as you know, is just across the river in Govan. And that's our three main centres, but there are two others as well, which I'll show you in this map. So that's where they're located. There's Inverclyde Royal as well, and there's the Valley Leaving. These are our community maternity centres. So these are our three main, but as you can see again, we're effectively centralising the service. However, in this instance, rather than having families travel to health centres where the centralisation was a concern, of course, the vast majority of pregnant women pass through the service in some manner for their 12-week booking appointment or for their 20-week fetal anomaly scan. So although it's centralising, we are actually optimising the availability of the vaccine, because all women are passing through the service. So cohort-wise, Princess Royal Maternity sees about 6,000 pregnant women through their doors a year. Queen Elizabeth, 7,000, Royal Alexandra, 3,700, so a grand total of 16,700 women pass through the doors each year. And some of that figure is made up from our other health board neighbours. So Lanarkshire is about 2,000 contribution to that, Highland 566, and small numbers for Ayrshire and Forth Valley. So there's a kind of cross-board service going on, and what we've agreed is if these women are in our service and they present, we will ask them if they've had the vaccine, and we'll offer the vaccine and notify the GP through whatever manner we manage to sort out. And we'll also need to, I think, arrange informing our colleagues in those boards as well, so perhaps another team to let them know that the women have been immunised. So still to do our EQIA for the service. Our uptake currently for pregnant women not at risk is 54%. I think, Vera, you were saying 52 for you guys, weren't you? Yeah. So we're sitting about 54. Flu at risk, 64, and pertussis is 67, which wasn't bad. But again, opportunity to improve, and we hope by having this captive audience while they get their scan, we can offer them the vaccines as well. So we hope there's real opportunity to improve here, because the current model relies on midwifery staff encouraging them to get the vaccine, and then the pregnant women having to go to the GP practice to get the vaccine. So there's this dependency on the women going to get it, whereas here we've got them. So if we've got them there, hopefully we'll get a good uptake. So for this, in this model, we did consider, I mentioned the preschool flu, we have considered a skill mix of different immunisers. So not just using band 5 nurses, but using perhaps healthcare support workers or other staff, band 3s and band 4s. And this is legally possible. It is absolutely possible to do that. Staff can immunise under, there's two ways to control it. One, it must be in their job description. They have to have the appropriate training, and that allows them to be covered by the health board's indemnity insurance. And the second thing is that they must operate under a PSD, not a PGD. So the patients must be screened either by a medical practitioner or a registered nurse or midwife on their behalf. And so you produce the screened and eligible list of patients to be immunised. And that done, then under a PSD, the band 4s or band 3s can actually immunise. So we have investigated this. We are not going to go ahead with that this year, I don't think, for the pre-Pfizer flu. But for the maternity model, it actually is the model we're going down. It's band 4 maternity care assistants. Now, that role is a particularly clinical role as it stands just now. And these guys will be basically performing an end-to-end vaccination service. So in other words, identifying the women, inviting the women for vaccination, delivering the vaccination, recording, data sharing with the GP, and being pivotal to the uptake reporting as well. So it's an end-to-end, a kind of one-person vaccination show. So again, 30th September is what we're aiming for. Identification is easier. I think Vera already mentioned this, or somebody else already mentioned this, because the women self-refer effectively. They self-refer into maternity services. And so we will mention in the track care letter for those appointments that they'll be offered their immunisation when they arrive. So it'll be included in the booking and the scanning letters. The data recording we're going to do via a midwifery system called BadgerNet, which I'm sure most of the boards in Scotland use. However, locally we're looking into some local contingency solutions in the next 6 months which will allow recall identification of those women who haven't had their vaccine. So I'm imagining a report of some sort that we can pull out of the system to see which women haven't had their vaccines at the 12-week or the 20-week or whatever, and we can chase them up and we can recall them. And again, we'll need to look into how we're going to data share with the GPs, which is a common theme. Obviously slick and as automated as possible, but the challenge is within the realms of what our IT allows us to do. And again, the national uptake reporting bit as well. Now, I originally had this for this coming October as well, but thankfully somebody says, are you mad? Move it to the following year, we're taking far too much on, to which I agreed. This is our biggest challenge and biggest cohort in Glasgow. The adult immunisations as a whole, so mainly flu and pneumococcal, but obviously shingles, and we're also lumping in here as well travel vaccines for adults as well. So for Glasgow, the flu cohort currently for under 65s at risk and over 65 sits at 370,000 in that 10-week period. That's 100%. So at 75% uptake, that's 27,750 patients per week over the 10 weeks, which is quite a lot of patients to get vaccinated, to jab. Somebody mentioned a conveyor belt, but that would be really appropriate in this case. If we set a clinic up, perhaps in Glasgow Airport or something, and they could be going along and just jabbing them as they go. So yeah, that's the most. This is the biggest challenge for Glasgow Clyde. This programme. And so yeah, it's cohort size and accessibility of service, because when you get such a vast cohort, if you start to centralise, you need big venues, and when you get big venues, you start to decrease the accessibility and availability of the service. So we have come up with our proposed model on the table, which we were aiming for this coming flu season, but I'll tell you why we're not. It's a two-pronged attack, actually. It's a two-faceted model. We're going to form HSCP adult or older people's services immunisation teams, and that's similar to the childhood teams and similar to the school teams that I showed you in the previous slides. Those guys will create immunisation clinics in centres to be determined, and that will be the main or the initial availability of vaccination for this cohort. So, for example, offered through October, early November. We're given the current suggestion is 2 strikes and you're out, so we'll probably schedule them a first appointment. If they don't arrive or it's not suitable, they can change it again. If they want to change it again a third time or don't arrive, or it's a DNA, we will then refer them to community pharmacy. So last year we managed to sort out some legalities with regards to community pharmacy being able to vaccinate on behalf of the NHS. And so our community pharmacy sector, we've been engaging with them in the last, in fact, since October last year, in fact, summer last year, and up until recently. And those guys are on board with offering vaccination. And how they're going to do it is mop up, so following that 2 strikes and you're out model with the HSCP clinics, and opportunistic immunisation. So in other words, they present at the pharmacy, they obviously are in an at-risk category, perhaps picking up salbutamol or Bricanil or whatever, or something else, so they're a cardiac patient or respiratory patient, or they're over 65, and they'll be asked, have you had your flu vaccine? So that's the opportunistic element. I think people were mentioning the opportunistic element of immunisation. So that's how we hope to capture it using community pharmacy. So in this way then, we feel we've got a kind of best of both. So we'll have a centralised model with a dispersed model. So one of the benefits of the GP model currently, of course, for Glasgow, 235 practices, is a dispersed and accessible model. So we feel we'll have a centralised model to absorb this huge cohort, to give the capacity to the system that we need, but also we'll have accessibility, geographical accessibility through the community pharmacy dispersed model. So for Glasgow and Clyde, we have 291 community pharmacies, and they range in size from the wee ones that don't even have the kind of consultancy rooms to the massive ones like the supermarket and Boots, who all have a much bigger capacity to offer vaccination. So yeah, I think I mentioned it'll be all adult vaccines offered by these teams. So we're talking about flu, pneumococcal, shingles, and the travel vaccines as well. This is our proposed model for travel vaccination in complement to the national travel health advice model. We're going, so in the next coming months, although we're not aiming for this October, we don't feel, it'll be the following year. We still need to carry out the gap analysis of the adult and older people's services. staff and resource-wise, similar to the childhood programme, exactly the same. And we'll need to negotiate, this is going to be quite crucial, an item of service payment in negotiation with our community pharmacy sector. So that's going to be our next challenges. Now, God, I've not changed this slide. Let me just say, it will be October 2020, not October 19. And the reason behind that is that in terms of the recall of this huge cohort for Glasgow, 370,000 patients, we feel that our local contingency, a development of a solution in terms of processes, in terms of staffing. So even if it's a manual process with processes, then you're going to need a heck of a lot of staff. If it's an IT process, then we're going to really be really clever and develop something pretty quickly. So again, in terms of IT data, identifying those under 65 at risk at the moment, that can only be done in the GP practice systems. Those guys read code the categories that deem the patient at risk. We also need to get relevant clinical data. So for example, contraindications for shingles, we need access to information. And we need to, importantly, we have nothing at the moment that would be able to schedule on behalf of those 235 practices patients. We've got nothing to schedule vaccination. We have considered, now I don't think I mentioned this, but in the pre-Pfizer flu programme for the pilot this coming October, we're considering having alternate models, drop-in models or scheduled models to see how they best work. In this cohort, a drop-in clinic could potentially be an absolute nightmare because it's just a huge amount of people could potentially turn up in one given night, and you would need to turn people away, which is a disaster. So we feel that we have to have a scheduling system of some sort. And with that, we'll need to create and record the 370, even although the uptake maybe be, of course, not 100%, we still need to have records for 370,000 adults in Glasgow and Clyde. And again, we need to work out how we're going to share the data with the GPs and how we're going to report national uptake. So for this reason, we've made a very recent decision that we think we're going to punt that out into year 3. We'll take pregnant women and pre-Pfizer flu this coming October, and this one's going to be punted out. And that's me. Thank you.
Okay, lots of challenges ahead. And last but not least, I think most of you know David Crowing from Lanarkshire. So David will just wrap things up, and then we'll bring everyone to the front table for some question and answers.
Sure. Is the presentation here?
Okay.
Where's the presentation?
I don't know, just follow after.
Oh, do they?
I think it did.
Collated.
It just
That's
did
fine.
the PowerPoint.
Here we are.
There you go.
There we are. Okay, thanks very much. Time's pressing on, so I think we'll have time for questions as well, Said, so not take too long, but I think a lot of the themes and sort of the cross-cutting stuff like IT and others have been mentioned a number of times, so without going into too much, I would be repeating that, those sentiments. Okay, so what I'm going to cover is what we've achieved in Lanarkshire in year 1 of the Vaccine Transformation Programme, what the plans are for year 2, what we've learned, and some questions. However, there's life before Vaccine Transformation Programme. So, in Lanarkshire, we had actually been dealing with the routine childhood vaccines for about 10 years or more through the managed service. We had a lot of anxiety from GPs at the time when we took that on. They thought their uptake rates would fall, they thought it would be a worse service and all the rest of it, but actually the uptake rates in Lanarkshire have been one of the highest in Scotland for the last 10 years, so I think that centralised service does work. And I think somebody mentioned earlier, I think, Scott, about the queue lists that are built up. You've got much more better handle of dealing with it when you do it under the managed service than you do with relying on the GPs. In Lanarkshire we have 100 general practices. It's very hard to have a handle on what they're providing, but if you have it under the managed service, it's much easier to deal with that. And we've also had the school-based team running for 3 or 4 years, and that's been very effective in terms of both the secondary school vaccinations and then the primary school for flu. So one of the challenges in relation to the childhood stuff was that when you condense the clinics into clinics that cover children from more than one general practice. You're unable then just to send back the SIRS form to that general practice. So what we do is enter the data into SIRS, and then we take out a composite list effectively, and then filter that into children for each practice through an email type mail merge situation, and that information we provide back every fortnight to the practices so they get the real-time information. The current IT doesn't really enable that. It's a paper-based report that would be about 8 weeks out of date as a maximum out of date. We've shared that information with colleagues whenever the vaccination programme started, so other boards have had some experience of the information that we've had, and if you're stuck or need further information on that, we do have sort of the SPSS programme and the standard operating protocol for that we can share. The school-based immunisation team, it works well, and it's got a schedule that basically covers the year. There's some pinch points within it where there's additional staff are taken on. There's always a difficulty when you're relying on bank staff or additional staff, but we try to keep that to a minimum, and we've spaced out the various vaccination schedules through the year to enable us to have as many of the permanent staff as possible, and some of the school team and some of the managed team are here today. So year one, really the two things that we've focused on have been the pertussis vaccine and the travel health side of things. So in relation to the midwifery side of things, I think we're fair to say we had a fairly slow start. We had engaged with them, we had explained what we were doing, and there really wasn't a huge bite on it from the pertussis, from the maternity services. They were a little reticent to get going, shall we say, and I think what the reason behind that was is because they were having a lot of service change themselves already, so they were engaging with pressures on the maternity services. They were looking at reconfiguring the way that they work to Best Start. So that's all, if you're aware of Best Start, which is about effectively providing maternity services more closer to the patient's home than they do through the traditional clinic side of things. So there's a whole process going on with that. So the maternity were not really, they had other things that they were focused on, I think it's fair to say. So we didn't really pressurize it too much, but we kept in touch, we've discussed it with them. And then suddenly before Christmas, we got a real bite on from them to want to do this here and to take that forward. So we have one of the localities, Lark Hall, it covers 5 practices, and they started to roll this out and to offer pertussis, and they said it's working great. We haven't had any women who've actually refused the vaccine. So, you know, in terms of the uptake rates and some of the difficulties, it's only a 20th of our population, so it's not going to make an impact to our overall numbers. But the feedback is that it's the uptake is very good, and people really are not refusing. And then they said, well, hang on, we're given the pertussis, why don't we give the flu at the same time? And the reason we didn't do the flu at the same time initially was because we started at mid-flu season. We didn't want to complicate things, but they were enthusiastic to do that. So they've been sharing their experience with other localities that are then taking on the Best Start approach. The Best Start will roll out in Lanarkshire over the course of a year. So it will take till December until all of the localities are covered by that. So in the meantime, we're looking at what can be provided with the 20-week appointment for scans. Now, in Lanarkshire, we have it's weighted that most of them are done at Wishaw, so there's 5 or something clinics that happen there at a time, so there's a good reason you could put in somebody vaccinating at that time, but in the other ones it's much slower throughput, so it doesn't really make sense. So anything that we put in the other hospitals will be as a temporary measure pending the Best Start rollout. So some of the feedback we've had that women appreciate being able to access the vaccine through the midwife, so the feedback has been good, and the midwives also enjoy doing that. They take it out, the vaccine out in a helipet, so they take it out to the home and then they'll administer it there at the time. And it's obviously in conjunction with other maternity care. It's not solely to do with the vaccine. So this will contribute to reducing inequality. So obviously some of the barriers that we've seen in terms of inequalities are the reluctance for people to come forward. Saeed had mentioned about the importance of the call recall system earlier, levelling out what those uptake rates are, but those are at at 2 years of age. So there's actually, that when you probably go underneath those figures a little bit, some of the more deprived populations actually have a slower uptake rate. So there are those inequalities there, and we think that making that accessibility and taking it to people will help reduce that. So I think our maternity teams are all, shall we say, a little bit down in the dumps, but when we offered them the opportunity to do the pertussis vaccine, this is the response that we got. So, so you can expect to have unfortunately we didn't have a before and after glum thing, but so the team has been supportive. We've given them advice and education, and we're available for support, but really they haven't had to avail themselves much of that at all. So the main, probably the thing that's taken up more work this year has been in relation to the travel health side of things, and pretty much probably a couple of boards were under quite a lot of pressure from their GPs to take on the travel health right from the start, and Lanarkshire was one of them, Borders was one, I think Grampian another. So some boards, like ourselves, had to think about this a lot quicker than some of the other boards, and we've had multiple workshops nationally about this, discussions about what's the best practice, what might be in the contract or not, etc., etc. So we have gone through a process of trying to understand what the ask is and how we might deliver that. So if people are familiar, then we've got a 3-tier approach, which is essentially that tier 1 is that people would consult a website or some sort of other pretty much lay type information, and then be redirected beyond that to either to get services for vaccination, or to be told that you don't need to have information, or to be redirected to your chronic disease management provider. So, Scott, I'm just interested to know, since you're going to Brazil, where did you get your advice from? So, and then the second level then would be where we go to actually that focused consultation on what might be the infectious disease advice for in relation to travel. So do you need vaccines? Do you need antimalarials that are directed to you as an individual? And do you need general advice that relates to sensible precautions in order to reduce the risk of infection, such as not drinking local water or whatever it might be? So we've had different ways of how that might be done, not only within Lanarkshire but in Scotland. So some people are talking about traditional face-to-face appointments. Our preference in Lanarkshire is to make this a telephone consultation, and we did have some professional concerns about whether nurses could make prescribing decisions over the phone. So essentially they would be taking a phone call from somebody anywhere in Lanarkshire. They would then say you need a Hep A or a Hep B or a typhoid, and that would end up in a prescription, and that person would then be able to get their vaccine at their local treatment centre, which would mean and reduce their need to travel. So that's really the theory. So we had a couple of professional concerns about whether nurses could do this over the phone. And we subsequently and fairly recently discussed it with our exec nurse director, who's said to us when we write the business case, she's quite happy to sign that off from a professional point of view, and we've discussed that to a limited extent with some colleagues recently. So we don't have any professional concerns about the actual act of prescribing to somebody over the telephone. The other issue was to do with people getting the vaccine when it comes to the treatment room. So we think that that's pretty straightforward in terms of it's a prescription, and that people then would turn up and simply get the vaccine in the same way as they would a B12. And I think there's obviously some peculiarities around the vaccine, but they're fairly limited in terms of what people need to understand. Our model would include involvement of the infectious disease service, the current travel health service that's provided at Monklands, with some clinical oversight and support and access to specialist information and consultation when required. So we've been discussing that with the clinicians, and I think they're moving more to supporting this. I think there have been challenges to this model from a national point of view, from the doctors and some of the travel health specialists, but I think we need to further discuss this and end up with professional support overall for it. But essentially that's our model. Appreciate that others have got face-to-face or a different way of delivering the tier 2, but essentially that's where we're looking at. So we're keen that the website and that first interface gets done nationally. We've had discussions with NHS 24. hopefully that'll progress, and then that'll be a filter to limiting and pointing people in the right direction. So I've actually learned something. So I'd spoken to a GP, in fact, this morning about this here, and said that we'd also have people who would be redirected to not only to the travel health side of things, the VTP travel health side of things, but to others who, and I use the words others who would be dealing with their chronic disease management, and the GP said, you've learned something. So I refrained from saying we would direct them to the GPs, because that would have been a disaster for me as well as the GPs. But I think if people are concerned about their asthma or their diabetes or something, who would usually advise you on it, and could you speak to them about it? And that's actually part of normal chronic disease management care anyway. But I think what we're probably saying here is we're not going to actively encourage everybody to make sure they get a check before they go away, but if they're concerned about it, they would be directed to it. So in terms of the next step, we've got the national business case will be coming through, and we'll be looking at the details of the business case for Lanarkshire and how that would be set up. And I think that the timescales are probably 6 to 9 months. Maybe I'm not sure for that NHS 24 one to be set up, but roughly that sort of timescale. And the treatment room model. So if we come on to year 2, we had a workshop last week, and we were looking at preschool and the school mop-up and the over 65s, really the routine age groups for flu and what might be done about that. We felt it went fairly well. We had people from the general practice, the practice managers, some nurse involvement, and others, and we thought we sort of had a fairly sort of measured approach to this. And then on Monday I got a letter from the GP sub. I almost didn't get it because it went somewhere else instead of myself, but it basically said you need to do all flu this year. So I think we're going to have to find a common ground somewhere in all of this here. But there is an element of expectation about the GPs wanting to shift everything pretty quickly. However, I mean, there are significant logistical issues in terms of dealing with the numbers. Our sense and our approach from the meeting and the workshop that we had was that we would be aiming to be running big clinics, followed, mass clinics, if you like, followed by smaller, pretty well populated clinics, and then have some sort of ad hoc sort of availability through the season, because it's very hard to say that somebody's missed it in October or maybe early November, but they can't get it for the rest of the season, when that wouldn't have necessarily been the case last year and previous years. So we did have community pharmacists at that meeting, and we're looking at all the various options about how that might be delivered. I mean, the main challenge for all of this here is really not to do with the vaccine advice. So it's not necessarily that complicated, a whole lot of this stuff. The complexity or the challenges in getting the staff, the resources, the IT, the premises, the information to patients to know what to do. I mean, I think I said to others earlier on today, I mean, if you didn't have another communication with over 65s about flu for the next 3 years, I can guarantee you that they'll turn up on their GP door on around about early October looking for the vaccine. So there is a behavioural element that's already happened there and will probably continue to happen. And part of the challenge is to be able to change that without confusing everybody and causing a huge ruction. So, and then the other more complicated issues are particularly the shingles side, as mentioned earlier, in relation to the contraindications and the potential risk factors, but also identifying the those that are at risk and how we do that. And clearly there's a role for general practices, I think, ongoing to make sure that they actually, inverted commas, refer people to this service. So the only way that people will know that somebody's got asthma, diabetes or something else is because the GP has labelled them as that or put them on a clinical system as that. So if that's what the GPs are going to have to do as a minimum going forward, and in the absence of good IT to link up to the systems, they're going to have to actively push that to the vaccine service by effectively a referral. So, I mean, we've had various discussions about how things are working. We've heard about how things are working elsewhere. I mean, generally speaking, we're pretty well involved in the primary care structures. We understand the priorities of the GPs. We've discussions about the finance and so on. So I think that's working reasonably well. We do have to align the expectations and also what Health and Social Care Partnership and others can actually deliver. But and we're working with people who can see the benefit of this, and we have seen some of the benefit of that, for example, with the pertussis already. So that's been encouraging. As I said, the challenge are people with multiple demands on their time. It is a change in the way that they do things, so we need to help understand what that change means and to support that professionally. There'll be wider workforce considerations for Tier 2 for the travel health service and wider. So there'll need to be people trained to be able to do that work, to be able to do the prescribing, understand travel health. But there are probably some practice nurses out there who might wish to continue to do this on a sessional type basis. So hopefully we will get staff in due course. So just to say, two models. If they look similar to Karen McGuigan, that's because they're probably genetically connected. So Karen's two kids here. So I think in terms of the progress, we're probably at the red area, but we're aiming for the summit at some stage.
Thank you, David. Can I ask all speakers this afternoon just come and take a seat in the front table? Okay, well, you've all heard the board, how they are sort of progressing from year 1 to year 3, what their plans are, some of the challenges and difficulties, aspiration. Clearly, hopefully, through today and to the BCM steering group, we can learn from each other, because clearly some health boards have got some thinking far ahead. For example, Lanarkshire done quite a bit of thinking on travel health, others haven't. Scott has already presented something what we are planning to do. So there are lots of progress going on, and hopefully today and through other contact we'll be able to learn from each other. However, has anybody got any question for any of the speakers, any of the things they've heard this afternoon? Yeah.
Question for Scott.
Yeah. Could you say who you are then?
Hi, my name is Mike Stalls. I'm a Health and Social Work Manager from NHS Lanarkshire.
Right.
I'm interested in the models you're coming up with for your teams and the reliance on your bank to provide staff. What's your plan B if the bank can't deliver?
Hello, does this work? Yep. So for the adult immunisations, we're hoping that the combination of the HSCP teams and the community pharmacy, that was going to be one of the main areas we're going to be concerned about regarding using bank nurses, just because of the volumes of patients we've had to immunise. So we're hoping that the new model proposal will take the dependency, or at least alleviate the dependency in the bank by using community pharmacies to mop up our opportunistic. So that's taking the main concern away from us. For the preschool flu, smaller cohorts, and so it's a smaller dependency. So we'll have discussions with our bank colleagues, and we've calculated, we've modelled how many nurses we need, and we'll see what the reality is in terms of dependency on them. But as I say, the biggest concern was going to be the adult programme and dependency on bank nurses for that. And I think we're going to alleviate that largely by using the community pharmacy sector.
Thank you.
Yeah, and before I ask David, David wanted to say something. I think one of the other things is that, remember, we still, as David said, we still got a large number of practice nurses who wouldn't be doing flu vaccine. And when you go around and talk to them about update, they said they will be interested in doing some extra work during the winter month before Christmas to earn some extra money. So one of the things we'll be doing is that doing a major recruitment campaign among practice nurses, saying that if they want to do some extra hours, here's an opportunity for them to. Now, we already use practice bench nurses for our school program, our school flu program, and we are relying less and less on them as our school immunization team becoming much more adept at planning. So it is a challenge, but I think something we may need to address in due course. So David, and I'll come back to you.
Okay.
I'm not sure that Scott fully understood the question here. I think, knowing Mags quite well, Mags is probably concerned, Scott, that your plan B involves taking nurses from Lanarkshire. So
No.
So
Max is looking for an answer to the question that's going to come across the horizon in the near future.
So any nurses that come across from Lanarkshire would be a Trojan horse. So you need to be very, very careful, Scott.
Any bank staff from Lanarkshire, you're more than happy to give them some extra income.
Can I maybe comment on that? Because I've asked it for a specific reason, because I've heard the models you're coming up with. We currently work with a school nursing model, and we also do our pre-5 immunisations. They're delivered in two very different ways.
Yeah.
And so we see a need for bank staff or fixed-term contracts in the winter period, but it's competing with multiple health systems in the same 3-month period.
Yeah.
And last year we really struggled just to fulfil the school team. So that's my worry, if we then grow that into a roving or a bigger adult service and how we do it. We also are now seeing, now that school teams 3 to 4 years old, we're seeing a churn rate in the band 5 cohort.
Yeah.
So we're constantly recruiting and sitting at a vacancy rate that's not acceptable from an operational perspective in an environment where the bank's fragile. So I'm asking it because, having been through the process, the reason we don't see the same churn rate with the preschool immunisation programme is they have other duties other than vaccinations.
Yeah. Yeah.
So it becomes an attractive post for a band 5. So it's just that how we think about our systems and around the fragility of an ever-decreasing workforce. Yeah. So that's my view on it. So that's why I was asking you, if you'd fix the problem, I'm happy to adopt it.
No, I mean, our concern in Glasgow was the adult programme, and if we were looking to use the bank for that and purely have the HSCP teams, for example, delivering, then we were really going to be hitting some real capacity issues and some real big discussions to be had with the bank. However, we feel that if we have this two-pronged attack, as I say, with the community pharmacy sector instead of and using the HSCP teams, then that takes a massive reliance off the bank nurses. And so therefore the school teams will continue to use the bank nurses during the school programmes, especially during the primary school programme, October to December. But probably a separate, maybe an overlapping resource for the preschool flu. As I said, those clinics will be running late afternoon, early evening. So there is scope to use an overlap of the same nurses, but perhaps expansion to a bigger pool. But as I say, the biggest concern was the adult programme, and we feel that we've removed a large dependency on that away by getting the community pharmacy sector involved.
And just to add that the Community Pharmacy Scotland did a survey of all community pharmacists in Glasgow and Clyde, of the 300-odd community pharmacies who they'll be interested in doing flu program, and I think about 80% said yes. So clearly there's a huge interest from community pharmacy to support the program. We just have to make sure that we can get the appropriate data as well as the, Scott mentioned service level agreement or some kind of item of service fee, appropriate training and so on. So I think we need to maximize or utilize all existing workforce that we have, community pharmacy, practice nurses, whoever out there. Some of the school immunization team might be able to do some weekends, because or the evening hours. So we just have to open it out to everybody that we can get, because we can't just produce nurses out of thin air. We need to use the existing resources that we have, and we just will try and see how it works. Yeah.
Hi, I'm Jean Donaldson. I'm also from NHS Lanarkshire. I'm Associate Director of Nursing. Just wondering, maybe Scott, but actually any member of the panel, I've heard a lot today about obviously the need to actually get IT so that we can actually exchange data in real time, okay? Yeah. What I'm also hearing is we've obviously got plans for this year and next year, and we don't have that IT infrastructure agreed. So my question is, I know that during October, November, the amount of medication errors increase, okay, and that's actually with adults getting the flu vaccine twice, okay, with the process we've got. How do we think we can mitigate against the increased risk, I would suggest, of duplication of vaccination while I've actually gone through the transformation programme?
It's a very good question. Who want to pick it? David first?
I think nearly all of us on this group here are involved in the national IT for the VTP. So it's something that we have thought a lot about. So I think there's a few things that need to be aware of and need to understand. The first is that there will not be complete solutions, IT solutions for each of these elements of the programme whenever they're needed. That's the first thing. The second is that there obviously needs to be some sort of interim fixes or some sort of workarounds or things put in place to try and mitigate that as much as possible. So the third thing is that some of the existing call recall that happens, say for the over 65s, will also need to be amended and switched off. So at the moment we have a single switch that basically sends the same letter to everybody in Scotland for over 65s, and it may be that in Lanarkshire or in the other boards we do something different for one practice and not another practice. So we need to figure that out and to switch that off. We need to start to gather the requirements that are needed for the changes that are needed further on. So the GPIT system is under a re-procurement exercise. That's not going to come in for a couple of years and probably be 2.5 until it's fully rolled out. Similar type timescales for the child health system and the community systems are either got interim solutions as in Lanarkshire or will need to have a permanent solution. So we need to start to build those requirements. I think the main thing that we can probably do at the moment is to be defining what we need. Okay, that would help the national IT group as much as anything. If there are bits of commonality or advice that we can do, then it can be prioritised and put together. But it certainly will not come with a promise that it'll be there from day one. We're just going to have to take workarounds, and they will carry clinical risks with them. That's why we need IT systems at the proper functioning integrated IT systems at the end of the day.
Anybody else from the top table got any comments? Christina, want to say something?
I've got microphonophobia too, just in case you don't know. So the risks for us are different in the Western Isles because most of our data from double vaccination come from the school team, and that was because the mop-up was carried out within the GP practices as well as the at-risk kids. So one parent would consent and the other parent might take the child to the GP for the vaccine, and then it would be double vaccinations. So we're hoping for our adults at risk that this will be reduced because we're going to be working out of the GP atmosphere and we'll be using their data in real time on their systems.
Okay, Pam, who led the IT subgroup in the VTP steering group, want to say something?
It was really just to say, yeah, absolutely, the IT and the data sharing is key to this, and we can't underestimate how complex this is going to be. And the lack of that is actually stopping some boards moving out of GP practice, that they are moving to centralised teams, but they are still working within practice. So we are very much trying to address this as a national programme of work. Yes, some boards are looking at what they can do locally, and there will need to be some contingencies, but we need to look at what we can do safely just now as an interim solution. And then, as David correctly said, we've got the changes to a GPIT system and the CAI and the child health, which is going to be key. So we're kind of doing it through a three-phased approach. What we need to do interim just now to support the boards moving forward, what we might get with early delivery of the child health system, and then what we're going to have to look at longer term when we've got the new GPIT systems and the full rollout of CAI and child health. So yeah, you can't underestimate how complicated this is going to be.
Alistair, do you want to say anything about the new IT system, when it'll be up and running and what they would... Alistair actually is the program manager?
No, I'm a business analyst on it,
Right,
and
okay,
I'm not the most technical. We've got technical guys way beyond my ability. Yeah, and I'll caveat it strongly by saying that we have, so the programme basically has a title Transformation Programme, and it does aspire to that. It has a very bold and ambitious vision, and we're working along with VTP to see how we can support that. I think the struggle we got is we've got a very complex series of healthcare interventions that carry some significant clinical risk with it, and so what we didn't want to do was go in and try and change that, or be, we've got great ideas, let's work with you and change how you do your clinical practice or how you do your call, recall and scheduling. It was largely that the health board said, we want to have kind of replace what we can do now just do that and that's enough. That gets us onto a new platform without involving more risk. However, the requirements went beyond the day one requirements, and so we have capabilities in that. Let me just say they're capabilities rather than that we will give you that at the start of implementation. But there's already a groundswell, including VTP, and because the programme was suspended and it's now really back up and running again properly, we've got a full team assembled and we really are making inroads towards this. There's a groundswell to say, while we're getting the configuration ready for day one, can we also be thinking about the next delivery hot on the heels of that? And David's spoken about that as well. So we're doing that in parallel. We're looking at how we might be able to support mobile working particularly. So one of the things that we've agreed is as a licensing model with supplier, and we may not have it in day one, but we have the capability with a mobile solution that will involve nursing teams that even with rural challenges will be able to take that data out to these kind of immunisation sessions and be able to record that data there as well. So that mobility helps with that kind of change, hopefully, with that workforce problems it might have to solve those as well. And also there's a capability to increase for things like one of the benefits, David, that you know of is the lifelong immunisation record. So whether it's that's the challenge is you've got disparate systems. How do we do information sharing? But certainly the capability there with the child health system is to be able to have a lifelong immunisation record if that's the desire.
Okay, clearly there are, as you can see, sort of longer term, if we can get the child health system, the CAI system up and running, we'll have a hopefully all singing, all dancing, interconnected IT system. But meanwhile, we may need to make do with something interim solution. And I think in the next couple of months, we need to get clarity what is doable nationally. So the local health board actually then say, well, if you're not able to deliver nationally, what can you do locally? And I think that's the thing we need to identify in the literally next couple of months, if the boards are going to run pilot for this year. So it is going to be a challenge, but we're all working together, and you'll just get there. And first couple of years may be a bit messy when doing the pilot, but hopefully in long term, we'll get there. Any more? Yeah, sorry.
Thank you very much. I've got two questions, if that's okay. My name is Rachel Fraser. I'm a GP in Ayrshire and Arran, and I've been very interested today to hear about the work streams and the aspirations in the other areas. And I just wanted to ask Elvira, our representative, if she felt that there was any learning really from today that we could perhaps take back to Ayrshire and Arran. And the second question was that some of the areas talked about centralisation of services, and I just wondered how they were looking to perhaps encourage buy-in from the parties, families, parents, children, to maybe travel a little bit further to get their vaccinations. Just thinking about this as a GP, how I'm going to encourage my patients to perhaps travel that little bit further. So, two questions, if that's okay.
So we'll come back to centralisation next of Elvira, and I didn't know that Joy wanted to comment on it as well as a DPH from Ayrshire as well. Sorry, Elvira.
Yes. So yes, there's been learning from today. We are already in contact. So I have frequent communication with some of my colleagues. But yes, so the objective is whenever we are able to move forward in any of these, I will be learning from the experience in Glasgow, the experience in Lanarkshire, the experience in other boards that have advanced more than we have done, to learn about potential options that we haven't thought of, or models of delivery on how to use, for example, the community pharmacies. Yes, the plan is to learn from this. There also, the thing is that we might not be able to learn from everything, depending on how the local decision-making process happens. So, for example, the majority of my colleagues use immunization teams, and I'm not sure that this is going to be the preferred model that's going to happen everywhere in Ayrshire, and sometimes the local circumstances influence quite a lot how you're going to implement things. So, for example, if we end up in 3 localities team, some of the learning from other colleagues that have pan-board teams might not be used in the same way, or things like, I don't know, in maternity services, Ayrshire, the system that maternity services uses Eclipse, which is different than the system used in in Glasgow, which is BadgerNet. So there are differences, but yes, the objective is every time that we move forward, if we know that some of the world is more advanced than us, if we try to speak with colleagues and try to learn from this. I don't know if Joy wants to say something.
Sorry, Joy.
Joy is the Director of Public Health in Ayrshire and Arran.
So basically, yes, Rachel, I think absolutely, because that's one of the joys of coming today. I haven't been round the table to hear all of the other areas, and I think there's a real richness just listening about the different approaches and also the concerns that are bubbling up in other areas as well, which sound really ambitious. So I think, yeah, it's given us food for thought, and I think we can go back, and there's a lot of the messages that have come out today that I think we need to present back to our primary care nurse implementation group to say, look, this is what's happening in other places and different models that are happening, because it will inform their thinking as well. There are particular ways that things are being done in different board areas that are forcing thinking differently. Some of the things that we've heard today are very different from the conversations that we've had in Ayrshire, and that's really good. I find that really refreshing and helpful. So.
As far as your second question is concerned, I think you're quite right. When you say centralized, you need to define what you mean by centralized. For example, I think as Scott mentioned, is that you need to have the right balance. And all health board, when they're planning their services, they need to look at some kind of geographical mapping to make sure that we're not putting clinics where parents can't simply travel. Now, Glasgow and Clyde, obviously, I've got 40 clinics. And from the data, we're closely monitoring the uptake data. And we certainly don't see any, luckily so far, any drop in the uptake rate. Lanarkshire have been doing it for some years now. Again, there's no evidence. So I think you're quite right. We need to get the right balance right. Centralized, yes, but we need to make sure that we don't make it too centralized. People can come. But if we do centralize, it needs to be balanced by some kind of dispersed model as well. And that's the reason why Glasgow and Clyde looking at adult program, some big weekend clinics, centralized, maybe 10 centralized clinic, followed by all those 200 community pharmacies. So it needs to have the right balance to make sure that we do not make it inaccessible than what it is now to our patient to maximize uptake rate. So I think that's what every health board needs to take into account based on their experience, geography, where the patient lives, and that's why local planning needs to happen at the board level.
Sorry, just to say, clarify, centralised, I mean by the managed service across Lanarkshire doing that as a centralised team, but it's actually provided in local settings. So I think in Lanarkshire we have as many childhood clinics as we have GP practices. It's just some of them are combined and some of them are peripheral. So
okay.
We've had those discussions, and yes, even another mile or two has raised concerns, but in practice it doesn't make any, parents are fine about it and when they understand.
The only thing that I would add to that is that apart from geographical, I would try to look at deprivation, because there would be areas that are, particularly in rural areas, with there is pockets of deprivations. When we know that for us is, well, you can take a car, you can take the bus, and depending of what the deprivation of the area and what's the local transport network, maybe we're asking too much from the patients, and that will lead to further inequality. So it's something that we need to be cautious.
And I think from the Scottish Government point of view and the GP contract, we made it quite clear to the health board, some health board may still have to contract with the local GPs. For example, if the remote villages, the only thing is a local GP practice, they may need to have some kind of agreement, the GP continue to deliver the service. So not necessarily mean that every health board in every location take the service out of GPs, as long as the local agreement will be locally enhanced service supported and basically resourced as well on top of the GP contract. So there need to be different solution to different parts of the country based on the population and the geography.
That's what I was going to say, Sire. I mean, the map I put in one of my first slides just highlights that completely, the challenges for NHS Highland compared to the wee Glasgow and Clyde entry on the map is completely different. So where the 40 health centres covering the 235 practices in Glasgow and Clyde's geographic area works, because the health centre by and large is very close to each of the families and children accessing those services. That's not the same for NHS Highland, obviously, who have a much bigger challenge, and so they need to come up with different solutions. So that partially centralised, it's not one mass clinic, but 40 health centres for the 235 works for us but it wouldn't work elsewhere.
Right, someone from this, yeah, go on.
Hello, I'm Shirley Marshall. I'm the senior nurse from the Travel and International Health team at Health Protection Scotland. David, if I could just ask you a question about Tier 2 of your travel health service, the consultation part, the video call, telephone call. Can I ask you how far along you've got with deciding what kind of training in travel health the individuals who will be providing that part of the service will have?
So I think we'll be looking to HPS to provide some of the training
Yeah.
for that. So
That's good.
So you answer your own question.
Is that right to start with then? Is it?
That was the correct answer.
So I think obviously the way I see travel health is a big box. Okay, so there's a whole lot of things that include the infectious disease side of things. It includes the chronic disease management. Includes specialist activity, mountaineering, or whatever else people might be doing, altitude sickness, and so on. What we want to make sure is what exactly is the service that's going to be provided by that Tier 2. My understanding at the minute is that Tier 2 is going to be about interpreting the risk in relation to vaccine preventable disease and anti-malarial advice, and then general advice about infectious disease. So my understanding is that that's more limited than what would be the training for a fully fledged independent travel health practitioner. So we need to look at what are the training needs for that aspect of it, and the needs. People need to be trained to be able to do the job that they're asked to do, and we just need to be clear about the specification of that job. So I think it's probably only been a couple of weeks since we've seen some sort of clarification of that expectation from general practice. There's a broader aspect about the whole aspect of what travel health involves and how that's delivered. And I think all of us probably here understand that travel health across Scotland is not as adequate as it might be ideally, and whether that's something that patients should be entitled to access or not is a different matter. But I think that's an out with the vaccine transformation programme. In my view, that's a broader issue in terms of what services are available. But we would intend that people would be trained to be able to do the job that they could, and what they would need to be able to do is to be able to prescribe independently for those vaccines. That's it. But we'll be looking to yourselves to probably tailor a programme for that. The numbers are around about 4 or 5, we think, for Lanarkshire. Multiply that by 10 for Scotland. It's that sort of order of magnitude that we would need pretty much full time.
Yeah, I think you're still trying to spec out what the Tier 2 looks like. Once you got that, identify training need, and then obviously then it'll be approach. And certainly we had some discussion with, what's the name again, nurse consultant? Lorna, and we'll do that. Okay. What's the time now? I mean, if there are questions, I'm more than happy to continue. If you've, right, go on.
Hi, I'm Joanne Anderson, Senior Nurse for Primary Care in Ayrshire and Arran.
Yeah.
2 things, because Ayrshire and Arran like to do 2 things. Firstly, just a comment, and we have been recruiting for Primary Care Nurse Bank, very specifically to be supporting our community treatment and care service and the demands of general practice. And not to rain in your parade, but with regard to the applications from general practice nursing, they were few and far between. So my concern would be, if we're thinking that we're reliant on them being on the bank to support our immunisation services, we may well need to think again. The vast majority of applicants were in fact from Band 5 nurses who were currently working in secondary care, who were essentially looking to find a way to transfer their career into primary care. And there will obviously be training implications for them to be able to support our immunisation service. So certainly from the practice nurse point of view, I don't know that we can pin all of our hopes on that from what I've seen to date. The second thing is just to go back to Scott, if I could, because I was very intrigued about your healthcare support worker and immunisation and the use of your PSDs. And I might have missed what you said, but I was wondering, and I think the phrase you used was screening, that somebody would screen. Yep. And I just wondered at what level that screener was, and were they in fact a prescriber to be able to delegate that duty?
So the primary legislation states that vaccination can be delivered on behalf of the Secretary of State of Scotland by a medical practitioner or by someone under their control and direction. So that's the legislation. Therefore, that's the legislation that allows community pharmacies now who will be able to vaccinate under our control and direction via a contract and via a PGD. So that's the sort of belts and braces to the control and direction aspect. Similarly, nurses also immunise under PGD in the Health Board, actually on behalf of a medical practitioner. So legally, the nurse is operating under the control and direction of a medical practitioner in their area. For the healthcare support workers, the same legislation applies. The control and direction element, again, is on behalf of the medical practitioner, so under their control and direction. So the PGD must be signed, PSD must be signed by the medical practitioner in that area, or the nominated medical practitioner who is willing to take the responsibility for that vaccination. Sorry, my brain's beginning to run out of vapor.
Take the
hit. Yeah. For a PSD, that the patients must be identified, as you know, and therefore to be identified as eligible for vaccination, it must be the medical practitioner or somebody acting on their behalf, just as a nurse would. So it must be a nurse or a midwife, in our case with the maternity services, who identify and deem eligible and appropriate for vaccination. That patient list is then produced, and therefore the vaccinations must be scheduled in that manner before the clinic operates. So under the PSD, that healthcare support worker can vaccinate that list of patients provided by the nurse or the midwife.
And what about the timing of that list then? Because I mean, certainly from general practice point of view, that was one of the things which kiboshed our healthcare support workers when we were talking to MDGS and indemnity, and that was around the time between that assessment and immunisation.
Well, for maternity, so the 12-week booking scan, you get your appointment, I think, maybe as soon as you identify and present yourself to the service, you'll get your appointment issued. So there are a number of weeks usually that previous to that appointment, your 12-week booking or your 20-week fetal anomaly, even easier. So for maternity, it's easier because the women, refer themselves into the service, and from that list of self-referrals or women who have presented themselves to the service, this forms the basis of the list that can be screened.
Yeah, because I was kind of thinking that it had to be done on the day, at the time. The assessment had to be done at the time and couldn't be done far in advance, because we could quite easily do that in general practice because we have a whole list of people who are coming for flus. So that was originally the approach that we took, but we were told that the assessment had to be done at the time.
Yeah, I think you're talking about adult immunization here. So, and also the school program, we send the questionnaire to parents, they come back, and actually screening done by the immunization team, Ben 5 nurses. And there are very little contraindication for either pertussis or flu. So I cannot see there are going to be significant contraindication which will actually stop a pregnant woman getting the vaccine. There are very few contraindications for these two vaccines. So I think to be careful that you're talking about a preventable vaccine, not a medicine that is going to have a significant contraindication. And even egg allergy, the Green Book is being updated. Egg allergy is not going to be a contraindication to flu vaccine in future. Even asthma, severe asthma, a nasal spray is not going to be a significant contraindication. So you're talking about the vaccines we've been using for many, many years, decade, and we need to be also pragmatic about try to putting barriers, saying that, well, we can't do it because not been screened previously. We need also look at exactly all they need one or two, three questions about just before the vaccination. Are you allergic to this? Have you had any acute illness? Have you had the vaccine before? Yeah. That's it, nothing else.
I know, but certainly that, even saying that, we weren't allowed to use checklists either. So that's the bit I'm interested in.
If I'm the doctor signing the PSD, I'll sign that I take full responsibility. That's what I'll do for Glasgow and Clyde.
So if you look at what happens in practice already,
Yeah.
If somebody maybe attends for a travel health clinic appointment and in your practice say, and you don't have hepatitis A or typhoid sitting there for them, they may come back in a week's time. They're not going to get a fresh prescription written for them whenever they attend that time. If somebody needs a course of hepatitis B, they're going to get 3 or 4 courses that may span up to a year. That prescription is going to be written and the vaccines are going to be administered against that prescription for up to a year, for example. So I think so long as there are processes in place to make sure that there's no contraindication has happened in the meantime, like anaphylaxis, then I don't see an issue with the element of delay. And other medicines are probably much worse. If you look at penicillin, people could be taking penicillin for 10 years for a splenectomy. It's been prescribed and continued to be prescribed.
I think certainly, when you're thinking of your HEPAs and things that you're saying, they've been written in advance, they come back a week later for immunisation. The nurses administering them in general practice are using a PGD.
Yeah. I think go back to Scott's point. I mean, it's not really an issue for the nursing staff who are administering it. It's an issue for the organisation that's setting up the system. So if the board's prepared to take that risk and to do that and to put that into place, then the nurse is protected because she's working under the policies of the board. So that's the way I would see it.
You do need to take it to the governance committee to make sure, I think Christiana want to say something, to make sure the board is fully covering the nurse and whoever doing the clinical procedure.
That's exactly what I was going to say, but our board are in support of your mindset as well for our nurses and midwives, and we will not be putting healthcare support workers in at this point. However, we will be watching and waiting and seeing what happens in GDC. But as we read the guidance, indeed, as we read the guidance and as we've been advised and supporting our staff, we're going down the same route as yourselves.
But we are well over our time, nearly 5 minutes to 4. Any other burning question before anybody else? We must finish at 4 o'clock with half an hour extra. But it's, I'm more than happy to continue given the interest from a colleague on the floor. Sorry.
Yeah, I've got a flight to go, but I just wanted to say thank you very much to Helen Murdoch and HPS because she helped me with.
Sitting there.
Was that you? We talked to you and all. So thank you so much for helping me with the stats, and sorry for my ineloquent explanation.
Anybody got any other burning question? Anything from the slide we need to address? No, nothing. Okay, well, if there's nothing else, I think it was quite a useful day. Thank you very much for all the presenters. So maybe if I can just put your hands together. Those who are here. And as I've said before, remember those presentations are going to be in the website, and you'll be sent an email with a link to an evaluation for the day as well. So please let them know how you thought the day went. And without further ado, as you know, there is a VTP steering group meeting coming up next month, and we can continue some of the debate at the VTP steering group. And thanks again for attending. Safe journey home.